Circumferential bladder neck dissection during robotic radical prostatectomy. Basically, to save the internal sphincter, which is located at the level of the bladder neck, which is also called the Lissosphincter, it is important to do a circumferential bladder neck dissection and not come straight down from the top. In this video, we're trying to show the circumferential bladder neck dissection, in which we do not go in the center but go onto the side and identify the lateral fat pad, which is between the prostate and the bladder. We dissect slowly with the Maryland and the scissors in the lateral fat pad. The Maryland is retracting the bladder medially, whereas the scissors are opening the fat fibers so that we find the space between the prostate and the bladder and go beneath, where we have already dissected out the seminal vesicles and the vas deferens. What you see laterally are the pedicles and the neurovascular bundles, which is dissected and peeled off more laterally. We are trying to peel off the bladder fibers from the base of the prostate. You see the fibers opening up. Your assistant retracts the fat with the sucker posteriorly so that more space opens up. You can appreciate the fibers of the bladder vertically going on and attaching to the prostate. Now we have punched through the opening through the fat between the prostate and the bladder to the previously dissected out space, and we exactly know where the prostate and the bladder meet. And this is what is circumferential bladder neck dissection, in which we sweep off the bladder fibers from the base of the prostate from the sides and not come in from the center. It is important to stay in the fat because that demarcates the exact junction between the prostate and the bladder, and we are sure that we are not into the bladder or we are not into the prostate. There will be some bleeding because of the pedicles on the lateral side. That can be controlled with the help of the bipolar Maryland forceps, and slowly we peel off the bladder fibers from the prostate. This makes sure that we do not cut through the bladder and the whole of the internal sphincter of the bladder is preserved, and we do not leave any part of the internal sphincter onto the prostate. This technique is usually done when there is no basal disease and there is no high Gleason grade disease at the base of the prostate. So this is where I am pointing, where I felt that the bladder neck would be there, and if I had come from the center, I would have opened the bladder there. But the actual bladder neck is quite distal to that, and this is where circumferential bladder neck dissection technique comes into play and helps in preserving the whole of the bladder neck. Again, the junction is clearly visible. It's important that your assistant also gives an equally good traction on the opposite side. The Maryland is always retracting the bladder, and you're pushing off the prostate with the help of the back of the scissors so that all the bladder fibers are peeled off the prostate. A good traction allows the bladder to drop off the prostate with just the help of the cautery from the scissors. Some bleeding here and there, which is controlled with the scissors. And we divide the anterior fibromuscular layer. It's a small prostate, so there will be some bleeding because the DVC starts bleeding when you divide the bladder neck. Similarly, on the other side, we're trying to find the fat on the other side. That's the demarcation to stay between the prostate and the bladder. As long as you're in the fat, you're safe. You would neither go into the bladder nor into the prostate. Again, some bleeding there on the lateral side, which can be controlled with the help of the bipolar. The fat on the left side is also dissected out so as to give us an idea where the bladder neck is. You can appreciate the vertical fibers just beneath the sucker. Those are the bladder fibers, and we have to stay distal to it. There is some troublesome bleeding here which is controlled. It's important to control the bleeding so that your field remains clear and you can exactly see the landmarks between the prostate and the bladder. A millimeter of difference here and there would decide whether we're able to save the bladder neck and the Lissosphincter or not. Our attempts at securing hemostasis. Once that's done, we come back to the other side. You can appreciate that on the right side almost all of the bladder has been peeled off the prostate, and we're reaching the midline where the urethra would be, and you can appreciate how the bladder is being peeled off from the prostate. In a conventional technique, we would have gone from the center to the sides. Here we are coming from the sides to the center, exactly dividing the bladder fibers where they attach onto the prostate. You can appreciate the seminal vesicle and vas deferens also coming in view from behind. And in the end, the bladder is attached to the prostate only through the urethra. The bladder on both sides have been dissected off the prostate, and only attachment remaining is the urethra in the midline. And when we divide the urethra, we are sure that we have not divided the bladder neck, and hence we have saved all the sphincter fibers around the bladder neck, which is the Lissosphincter, which is the internal sphincter responsible for maintaining passive incontinence. This technique is really good in preserving the internal sphincter, and our results have been very good. We have done this technique in about 100 patients, and most of our patients are dry after removal of the catheter and at most 2 to 3 weeks after the surgery. None of the patients have required to use a pad or a diaper beyond 3 months, all those who have had this circumferential bladder neck dissection. What's important in radical prostatectomy is the functional outcome of these patients, and these small tips and tricks go a long way in helping the patients regain their quality of life. Urinary incontinence is a major drawback after robotic radical prostatectomy, but with advancements in these techniques and with excellent oncological and functional outcomes, especially with the robotic assistance, we are able to give a very good functional quality of life to our patients, while preserving the oncological outcomes and not compromising with it. You can see that we have opened the urethra. That's the urethral tunnel that we are opening. The catheter is coming in view, and we know that if we are opening the urethra, obviously all of the bladder neck is spared because we've not even gone into the bladder. The catheter is pulled back and then retracted with the fourth arm and hitched up so that the prostate gets hitched up, and the rest of the dissection at the prostatovesical junction is completed. You can see the urethra in view where the sucker had just pointed. That's the urethra. So we've opened the urethra, preserved the whole of the bladder neck. You can see how small the bladder neck is, and the fibers, circular fibers all around the bladder neck, you can see how thick and chunky they are, and those are the muscle fibers that are responsible for the continence in these patients. If you're not sure in the midline, then again go on to the sides, because the sides will tell you exactly where the bladder and the prostate meet. You can appreciate the good thick muscle fibers all around the bladder neck. We see the fat in between. Fat tells us that we're in the right space, that's between the prostate and the bladder neck. Whole of the bladder has been dissected off the prostate, and we went from the right side to the left instead of going from the center to the sides, which is the conventional technique done by most of us. You can appreciate the bladder neck there. It's a good chunky bladder neck, and the fibers are well preserved, which will help in the continence in the long term for these patients. Some remaining attachments there on the left side, which are also taken down. That's the SV and the VAS coming into view, and that completes our circumferential bladder neck demonstration.